Hi, everyone, and welcome to the fifth session of our Climate, Health, and Healthcare Speaker Series, which will be focused tonight on mitigating the climate harms of healthcare. And we're so excited to welcome our three amazing speakers for tonight, Sean Christie, Ali Abbass, and Jean Wilson.
So if you've attended our previous session, tonight's going to work similarly. So our three speakers are going to give their talks, and at the end, we will do a question and answer. So please feel free to type your questions in the Q&A box, or if you'd like to direct message them to Vienna and I, go ahead and we'll make sure we get to them.
And as a reminder, participants who attend 4 out of the 6 sessions and write a short reflection at the end of the series are eligible to receive a certificate. We sent out further details on this about the reflection via email last week to all those who have signed up for the series, so please don't hesitate to email us if you have any other questions or concerns about this.
Perfect. And before we get started, we want to take this opportunity for a land acknowledgement. So we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land.
Thanks so much, Emma. I'm going to start off by introducing our first speaker for tonight, who is Sean Christie. He has attended medical school and neurosurgical residency at Dalhousie University and then completed his fellowships at the University of Chicago and the University of Calgary. He's currently a professor at Dalhousie, where he heads the neurosurgical spine program and serves as vice chair and research director for the Division of Neurosurgery. I'm going to stop sharing, and then you can go ahead, Sean, whenever you're ready.
Okay. Does that come up there?
So you got to do the switch, yeah.
Do the switch again?
Yeah. Perfect. Looks great.
Looks good. All right. Well, Emma and thank you very much for the opportunity to speak here and the introduction. This was fortunate to do this again last year, and this is a really great initiative. Kudos to the University of Toronto and the med school green team there. I hope you guys keep this going. It's important. So I know that time is fairly short, so I'll try to keep this to under 10 minutes so that there's lots of time for the other presenters and for interaction, because that's probably the most important thing. So I guess what I'd like to do today is just perhaps, frame a concept and get people thinking a little bit. I'm not going to suggest that I have all the answers or even addressing all the problems. But what I encourage you to do as you complete your medical school and get into your residencies and then into practice is really start thinking not only about the clinical aspects of what you do, but as it pertains to this talk, the environmental impacts of what you do, and just look around you. And I really, really emphasize, don't be afraid, and encourage you even to ask questions as to why things are happening. So because this is a med school type talk, I thought that we'd begin by framing it around a case. So this is a 70-year-old person with a history of cancer, and they present from a palliative care service with intractable back pain, and they can't go home because they require parenteral narcotics because of the pain. And just not to belabor the point too much, but we can see a mid-thoracic compression fracture here, and I was asked to see if there's anything that we can do to mitigate their pain. And fortunately there is, so we can do a procedure called a cement augmentation. There's different ways to do that. I do it with a technique called the kyphoplasty, but that I don't think is neither here nor there. But basically we cannulate percutaneously the fractured bone, and then we can try to reduce that fracture, and we put some cement in there to stabilize that fracture, and that provides support. And in this case, you do this through a couple of small stab incisions, and the patient goes home the same day and then rapidly is able to titrate off their medication or most of their medication, and have a much more interactive end of life period with their family. So the patients are very happy, and we're very happy. And then And then you step back and you say, well, this has all been very successful. But then if you look at it through a slightly different lens, to do that 1 hour procedure, this is the trash that we generate, right? So the whole kit, everything that we use to do that procedure on the left is all disposable plastic, which all goes in an incinerator. And everything on the right is all the packaging and wrapping and drapes and gowns and all the stuff that's just thrown in the garbage, right? And so when you sit back and you say, well, on one respect, I think we did good. And in another respect, we do. So when we started looking at this, oh, it was a number of years ago now, at our hospital, we had two main modes of disposing of waste from the OR. So we'd have yellow bags on the left, and we'd have dark or black bags on the right. And as you can imagine, the black bags, just like anyone else, they goes in the landfill, and the ones on the left and the yellow bags, those go to the incinerator. And there was very little, if any, recycling that was going on at all. And we just sat back and said, this just doesn't feel right. So, the OR is a relatively resource intensive area. It doesn't take up a lot of real estate within the hospital, but it does generate a lot of waste, up to almost a third. And certainly what we see in our OR is fairly consistent with this, and that an operation can produce more waste than a family produces in a week. Now, there's some tricks and caveats, I think, that we have to think about when we're looking at the OR in particular. And some of the challenges that have been put forth is that operating room sterility is so key in reducing risk of infections in surgical site, but also in healthcare workers that could be exposed to infectious agents or what sort of thing. But when you look at it, when you start to really dive into the environmental choices, you can really see that we can get around a lot of those issues, but it does need to take some education and some willpower. So looking at our site, I'll just give you a little bit of a snapshot of what some of the challenges are that you're going to kind of come up against. So if we look at our site, and we did a survey of our department, and overall, I'll just give you a quick snippet of this survey, but overall, there was a large percentage of people that felt that climate change is an important issue, right? And then as you start to probe a little bit further, the numbers start to change a little bit, and you say, well, does climate affect health? And still, I think, you would see that there's a fair number of people that are either strongly agreeing or somewhat agreeing. And then as you spin it a little bit more and you say, well, does health affect climate? And the strongly agree number continues to go lower, right? We still have some people agreeing, but it's not the same in terms of whether or not climate is an important issue. So I think that within healthcare, we have our backs up against the wall a little bit. And we need to think better about how we present these arguments and how we move things forward. So what are some of the barriers to waste management in the OR? And I think you look at this, I look at this in three different ways, right? So there's the same piece that we demonstrated in our survey. Not knowing what can be recycled is basically an education piece, which I think is, I don't want to say easily, but is, can be mitigated. The next group, I would say, is the second one, that's handling contaminated materials. And that's where we're seeing the biggest pushback right now, is with our infection control people in IPAC, and really trying to educate and go through the literature and prove that everything doesn't need to be incinerated, for instance, and some things can be recycled. And then there's the last group, which is the bottom four, which I think is just the 10% of people that aren't going to agree to anything, and they're just looking for some sort of excuse. So again, from a contextual standpoint, this will be almost the end of what I want to try to illustrate to you today. So we did a survey, and we amortized this over a year in our OR. And this is just one hospital, and those the services across the bottom. And just to give you a feeling for what this shows, so we look at the different services, and the yellow bars are the bags that go to incineration, and the black ones go to the landfill, and the bars that are supposed to look like clear and then blue are the bags that were recycled. And this is after we did our education kind of blitz and really improved things. But it doesn't look like it here, but there were very little blue bars before. You put this in context, these are the average number of bags per case of garbage. And these are the big, large bags. These are the number of cases that were done by service over the year. And then that gives us an estimate of our annual waste, right? So we've recycled 11,000 bags in this one hospital, 13,000 go to the landfill, and we still incinerate over 8,000, right? So it doesn't feel like we really made much of a hit, but we can start to turn this around a little bit further when we look at what the cost of these things are. And this is where the other advantage that you can do is ask questions and then get your data, then back it up with cost. And the yellow bags are heavier because they contain waste and water and things like that. And at an average of 10 kilograms per bag, incinerating those costs over $100,000, which in a whole hospital budget's not a lot, but still, it's not small change, right? I mean, you can do a lot with $100,000. Going to the landfill is considerably less, but at 5 kilograms a bag, it's still $10,000. And then recycling, we don't have a number for because that's repurposed. So I think that we were able to shift things a little bit, and we started with no recycling and brought some recycling on. And I think I tried to illustrate a couple of the challenges that we face and that we have to kind of work around. And the last thing I want to lead you with, that I don't want people to walk away thinking that recycling and waste is the sole contributing factor to the environmental crisis as it pertains to healthcare. And it's not the only thing to look at, but it's one tangible thing that people that aren't deeply involved in the field can wrap their heads around, and it can be used to gain momentum for other bigger issues. So I think that there's a role for these things. I think there's many other strategies, some of which you probably hear of tonight or in other sessions. But I just start off with that to kind of set the mood. So I'll leave it at that for now and pass on to the next person.
Perfect. Thank you so much, Dr. Christie. Always nice to see Peggy's Cove as a fellow Dal alumni. So I'm really excited to introduce our next speaker. So we have Jean Wilson, who is a nurse practitioner who has practiced for 30 years in primary healthcare and epidemiology. She's currently an assistant professor with the Lawrence S. Bloomberg Faculty of Nursing, teaching in the graduate nurse practitioner program. So welcome.
Thanks, Emma. So I'm going to share my slides. Try to share my slides. Are we good?
Those look great. Yeah, that's perfect.
Great. Okay, so just, sorry, moving things out of the way here. Sorry. So I'd like to thank the organizers for inviting me to come and speak a little bit about the work that we have been doing with regards to sustainable healthcare systems and the environmental impact specifically around meter dose inhalers. And I'll talk a little bit about how I got involved in this, but it's really around the work that we have been doing around calling for clinical practice change for prescribers. So I don't have any disclosures for conflicts of interest for this talk today. So a little bit of information around the background for this project. So this started as a larger group, the Sustainable Health System Community of Practice here in Toronto is a collaborative between the Toronto Academic Health Sciences Network and the University of Toronto Council of Health Sciences. And this is a large community of practice that was started in 2020. And it has several small working groups associated with it that have actionable items that impact, that are based in the healthcare system that we can do to mitigate our impact on climate and climate change. And so one of the actionable activities and working groups that was recommended was sustainable inhaler use, and specifically a shift from meter dose inhalers to dry powder options when it was appropriate for our patients. And so the working group for sustainable inhalers was established about 1.5 years ago. And the purpose of the group was to create evidence and ideas, leadership and advocacy around reducing the carbon emissions specific to inhalers and inhaler prescribing. And through this, it would be a coordinated action for both education and research. So this is a working group that has a secretariat and support from the Dalai Lama School of Public Health and a Sustainable Healthcare Center. And then the membership is made up of 3 major prescribing groups here in Ontario. So that is the Lawrence S. Bloomberg Faculty of Nursing, so that's me, through the Graduate Nurse Practitioner Program, the Faculty of Pharmacy, and then the University of Toronto Department of Family and Community Medicine. So the folks that I work with, and I say this as a novice person to environmental issues, always been a passion of mine, but really I don't think I understood, and I certainly didn't understand the impact of the healthcare system on greenhouse gas emissions and climate change. This is our working group. We are led by Dr. Kimberly Wintemute, and we have, as I mentioned before, multiple working group members. We also are in collaboration with an academic family health team, the St. Michael's Academic Family Health Team, and contributors from there is Dr. Samantha Green. Brenda Chang is a clinical pharmacist who is responsible for many of the quality improvement toolkits that I'm going to talk about today. And then Gabrielle is a student of hers that is passionate about this and has contributed to a lot of prescriber tools that can support prescribing in a greener way. So I know most of you have heard all about this, and so in Canada, the healthcare system obviously contributes to the overall greenhouse gas emissions in Canada by 4.6%. And the reason that I bring this up is really the comparison that I'm going to talk about just briefly with regards to the UK. And that is the work that they have done in the national health system there. And their health system also contributes approximately 4 to 5%. To the greenhouse gas emissions. And they have done quite a lot of work around digging into the different areas that contribute to this. And I just wanted to point out sort of where we come from as a working group. So obviously medications is a very large portion of that. But on the left-hand side, the meter dose inhalers, are right there with the anesthesia gases, and it makes up about 5% of the overall contributing greenhouse gas emissions. And for the most part, the meter dose inhalers are actually 3.1% of that 5%. And so part of the working group felt that this was an area that was probably low-hanging fruit for us to look at as prescribers. And then, of course, the work that they've done in the UK also sort of naturally moves on to the fact that if you're looking at medications as contributors to the greenhouse gas emissions, and inhalers being part of that, that really prescribers are the largest target area. So our working group has really focused on primary healthcare prescribers and doing education and providing quality improvement tools to support them in a greener option when it's appropriate for their patients. So when it comes to meter dose inhalers, the UK also has done quite a bit of work around doing some evaluation of meter dose inhalers. And they contain high levels of hydrofluorocarbons that act as a potent greenhouse gas, gases. And when released into the atmosphere, cumulatively, they actually contribute a fairly large burden to greenhouse gases. And so the work out of the UK has indicated that a single meter dose inhaler, so about 100 doses of medication, is calculated to contribute a carbon footprint that is the equivalent to a 290-kilometer car ride. And so choosing other options such as dry powdered inhalers or mist inhalers is a greener option. And that is the basis for some of our conversations. Now, I preface that in also saying that right now the focus has been on greenhouse gas emissions. There's a whole other conversation to be had around how inhalers are created, really from beginning to disposal and recycling and all of that. And that information and that work is ongoing. But the work that we did in the last year was really focused around the greenhouse gas emissions. So this is just a slide to also sort of demonstrate to you the difference between the inhalers. And as you know, CO2 equivalence is a metric that's used to compare emissions from various greenhouse gases on the basis of their potential for greenhouse warming. And so we see here from this slide that the meter dose inhaler actually has significantly larger amounts of CO2 equivalent in comparison to some of the other dry powdered inhalers as well. So the work that we did with the working group was over a 6-month period of time, we created a webinar, an educational webinar that not only talked about our climate crisis and the impact on health, but also about the meter dose inhalers, as well as greener options when it was appropriate. We also talked about the guidelines, the asthma guidelines, the COPD guidelines with regards to appropriate prescribing of the inhaler when it came to not over prescribing inhalers within clinical practice, which tends to also be a really big issue. We videotaped this or recorded it and provided it on an open access website that is housed with the Dalai Lama School of Public Health in their Sustainable Health Systems Center. And it's an option for people to review again, as well as share with other providers. We have, within the toolkit, we have inhalers, inhaler charts that show greener options for prescribing and support prescribers in making a greener choice. We also have favorites for electronic medical records. And I have to say, our clinical pharmacist has been integral in these tools and really requires a great shout out for these. We have promotion letters to support community pharmacies in encouraging these choices with other providers, and also letters for patients to understand the importance of this and to work with your relationship with your practice, patients in your practice, to promote this. And if they choose to do a DPI that works for them, then supporting them with video links that help them to utilize the new delivery system. We have office posters that are printable, and then examples of resident and student QI projects for students in these areas that may be interested in trying this. And as I said, it's all housed at that website. So we had really good attendance for the webinars. Our webpage has had about 4,000 views, and each one of the different tools also have had a lot of clicks and downloads. We spent a lot of advocacy time as well with the provincial drug benefits program to try to encourage dry powdered inhalers on the formulary. And we've talked to them about some LU codes that actually prevent the use of dry powdered inhalers that are now actually recommended through the new asthma guidelines that came out in August 2021. We have also done advocacy work at the federal level with CADIF, and CADIF has been keen to be sort of part of this dialogue and asked us to present at their symposium. And then we are in the process of doing some evaluation initiatives. As some of you may know, with Cascades, there's now a national advisory committee that's looking at trying to spread this education as well as great quality improvement tools for other primary healthcare providers and prescribers across Canada. So I have to put on my hat for being an educator within the nurse practitioner program. We've now integrated this information into our pathophysiology pharmacology course that's over 2 semesters, especially the respiratory modules. I teach the Global Health Nurse Practitioner course, and we have full environmental health modules now that talk specifically about the impact of the healthcare system on environmental crisis right now, and how it is that we can start creating some of these sustainable changes. And then we've also integrated this into their advanced health assessment and therapeutics course as they head into their practices. So that's it for me. Thank you so much for your attention. I'm over a little bit. I'm sorry about that.
Thank you so much, Jean. That was great. And it was really interesting to hear about, oh, sorry, my camera there. It was really interesting to hear about all the initiatives you're running. That was great. Thanks so much. I'm going to introduce our final speaker for tonight. Ali Abbass is an anesthesiologist at St. Joseph's Healthcare, Unity Health Toronto. He is fellowship trained in regional anesthesia and is a lecturer at the University of Toronto. He has been an avid sustainability champion and began his stewardship role over a decade ago when he introduced a recycling program in operating rooms. Slides look good.
Awesome.
You can go ahead whenever you're ready.
Thank you so much. Good evening, everyone. And thank you to the organizers again for this opportunity today. Now, you all have had some very fulsome sessions on the many aspects of how healthcare, the environment, and the climate are all interlinked, and how we, especially in healthcare, have even more of an ethical, moral, and professional responsibility to mitigate the environmental harm that comes from the provision of our care. On top of that, no disclosures, by the way. On top of that, I work at a Catholic institution, and His Holiness Pope Francis put out his 105-page encyclical entitled Laudato Si on the care of our common home, giving even further inducement to make climate smart care a top priority. If we do not, then quite frankly, would be rather hypocritical, and the oath many of us took and will yet take will be in vain. As you heard, I too am an anesthesiologist, and I've been involved in this side hustle for over a decade at my institution. It's been an interesting journey, frustrating and daunting at times, but necessary and worthwhile. Present day, we're fortunate to have what we recently renamed as our Environmental Sustainability Advisory Committee, which has an executive sponsor and is composed of engaged individuals representing key stakeholder groups who inform and guide our sustainability work. Recently, the two chairs of our committee were invited and presented a sustainability strategy to the Central Executive Committee at our network, which was a huge and critical step forward in hopefully establishing a formal sustainability mandate and goal. The great work that the Center for Sustainable Health Systems, along with the TASN community of practice, has been doing, I believe, has been instrumental. Now, we have to realize that all we have is this one planet, and the magnitude of the problems we're up against is sometimes very overwhelming. To sit with these truths is scary. I recently read On Time and Water by Andre Magnusson, which I recommend, by the way. And he is the individual who wrote on the memorial plaque of the Ökjökull in Iceland, the first glacier to lose its status as a glacier, official status. When you read this, one goes, oh my God. I mean, I cannot solve the world's climate problems, but at the same time, I can't put my head in the sand and hope this is all going to go away. And I will not let the magnitude of all this dishearten or discourage me from doing the right thing, even on an individual level, because I believe that what each of us does will make a difference. We need action from top down, bottom up, and sideways, from individuals to populations, from government levels to grassroots. And your actions and those of others around you will continue to build and catalyze the change that we need. All of you being here for these sessions is testament to the engagement, your engagement in mitigating the effects of our sector on our communities and our planet. And the opportunities are truly endless. To quote the editor of the British Journal of Anesthesia from 2021, the British cycling team won 8 gold medals at the 2012 London Olympics. This success, it has been suggested, was attributable in part to the philosophy of the aggregation of marginal gains, small improvements every day, everywhere and anywhere that have a compound effect. This concept has gained traction, and we believe that it should likewise be applied in sustainable healthcare. So with that today, I'd like to briefly share some examples of the initiatives, some initiatives, old and new, that I've worked on to reduce our environmental impact in the OR. Back in 2013, having been inspired by a colleague in Australia, Dr. McGain, who helped start the medical PVC recycling initiative out there, I started making some calls and reached out to a recycler here in Ontario, gave them a tour of our ORs and showed them the general workflow and the generation of PVC waste, and that this waste was generally clean. I got them in touch with the Australian recycler so that they could exchange notes, and I was able to answer their staff concerns about risk and contamination. Once they agreed in principle, what was then called our Green Committee held meetings with internal stakeholders to figure out the logistics and specifics, and we finally started a small pilot in our ORs to recycle PVC, the first in North America. We're able to collect PVC fluid bags, oxygen masks, and tubing. We have since expanded our collection, of course, and in September 2020, Environment and Climate Change Canada, along with the Vinyl Institute of Canada, started the PVC 123 initiative to help hospitals start a medical PVC recovery and recycling program. As of now, I understand 16 hospitals are on board. Now, you've heard from my respected colleague, Dr. Anita Rao, about the greenhouse gas effects of inhalational anesthetics. Desflurane is by far the worst climate offender, and nitrous oxide or laughing gas is right there with it. We made a number of related changes to lower our anesthetic gas impact. General education and reminders are critical, but system changes are also important and useful. In 2019, after having visited a colleague at a hospital in BC, I fortuitously learned that their gas machines, the same as ours, defaulted to 0.5 liters per minute with sevoflurane, as compared to our 2 liters per minute. Now remember that anesthetic use is proportional to fresh gas flow, the oxygen or air mixture that is running along with the anesthetic gas to the patient during the procedure. Many of us would manually decrease the carrier gas flow, but many would not. It was not a forced function. And so human behavior as it is, one could forget, even if one wanted to do something, or at other times we could just be plain lazy. So this was a very important discovery. It was in fact something that was possible to do. So I engaged my department members and presented the benefits and addressed the concerns, talked to OR admin. This would then take away the need for manually turning down the flow. It would reduce the consumption of sevoflurane, less emissions, less cost. The reason for the 2 liters per minute is because the manufacturer did not want to do a study to show the safety of sevoflurane at low fresh gas flows, and obviously cut into its profits. And so the monograph still states 2 liters per minute as the recommended flow. And the reason is theoretical concern for the production of something we call compound A, which is a nephrotoxin in rats. Now, without boring you with what is actually a very interesting history of industry and competition, certain countries do not even have any monograph flow restrictions. And after millions of worldwide anesthetics, well, we've pretty much figured that compound A is a unicorn. It's a non-issue. So we reached out to our biomedical engineering department and had them reprogram our gas machines to deliver 0.5 liters per minute with sevoflurane as the default. And nobody would have to do this manually anymore. So as I say, this decreased our sevoflurane per case use overnight by 4-fold. And to add to that, I heard just last month that there's a new software upgrade for our machines that will further allow us to decrease the flow to 0.3 liters per minute. So we're looking into this. The pandemic did delay our removal of desflurane by 1.5 years, but in November 2021, after giving another set of rounds, we became the second hospital in Ontario to remove desflurane from our formulary entirely. In March of this year, we trialed exciting new technology called MEBSORB, and Dr. Christie may know about it because it's by a company based in Halifax, DMF Medical, and the inventor is a Dalhousie anesthesiologist, Dr. Schmidt. This technology replaces a key component of any anesthetic gas machine, the expired carbon dioxide absorber. It contains many small beads of strong bases which absorb the expired carbon dioxide and prevent its rebreathing. And it replaces it with a selective membrane system. So instead of using 1,600 single-use plastic absorber canisters per year with resulting plastic and chemical waste, one could use a single membrane canister per OR per year. And the canister is reusable. The membrane just gets changed. So our experience has been very positive. We provided feedback to the company. And this would be a system that will absolutely nullify any concern that anybody might have about compound A, because the membrane is inert and there's no chemical reaction. And there are also other benefits. Next, I'll share briefly how the pandemic actually brought some benefit. Given the nature of this virus, guidance at the time was to avoid whenever possible any aerosol generating medical procedures. And airway management is an integral part of general anesthetics and is considered an aerosol generating medical procedure. So to be able to effectively and practically provide safe anesthetic alternatives was paramount. Now, if someone was coming in for, say, a 30 to 60 minute short day surgery procedure like a knee arthroscopy or minor gynecologic or urologic procedure, a spinal anesthetic was an option. But the local anesthetics we had were generally too long acting or came with some potentially unwanted side effects. So the surgery would be over and the patient would still be immobile and patient discharge would be delayed. So the only local anesthetic that could provide the most suited duration of anesthesia was taken off the Canadian market in 2012. And I spoke of this last year because the manufacturer changed their business direction. Chlorprocaine was still made and used in Europe and the US. After many failed attempts by myself and others over the years to get industry to manufacture domestically or get government to allow its import from the US, for example, the pandemic hit and laid bare the need for this agent. In collaboration with colleagues in Halifax, we did a survey of Canadian anesthesiologists to assess the interest in having chlorprocaine back in use. The results were published in our Canadian journal and provided to industry and government to demonstrate and help support our request. Other like-minded colleagues in Quebec also raised the pressure, and Health Canada's drug shortage unit finally approved chlorprocaine and provided the Canadian public with more care choices and sustainable ones at that. Now, sadly, I had a slide, but it seems to have disappeared. But Dr. Forbes McGain, who I talked about earlier, who inspired the PVC initiative, published an important study in the American Society Journal a few months ago that compared emissions from general versus spinal anesthesia using a life cycle assessment method. And though the study sample size is small, it was very illustrative. And the results extrapolated for a place like Ontario, where electricity generation is 96% non-fossil fuel based. The provision of spinal anesthesia appears to have significantly less emissions than compared to a general anesthetic. Now, lastly, I'll mention, you have surely heard that reusable supplies, despite the need to clean and sterilize them and the resources that go with that, are generally less of an environmental burden than their single-use counterparts. When I spoke last year, I talked of the life cycle analysis published a few years ago comparing single-use versus reusable laryngeal mask airways, which are a component that we use daily as we provide general anesthetics. So we did our due diligence since then, and next week we're implementing reusable laryngeal mask airways. These devices can be used up to 40 times. By the 17th use, they'll be cost neutral. In 2019, a representative year before the pandemic hit, we used 2,100 laryngeal mask airways. With these reusable ones, we could decrease that use to 50, just over 50 over the year, and hopefully half our cost. So to end, oopsie, I'm learning as I go, just along with all of you. And I truly believe sustainability needs to be embedded in everything that we do. You heard from Dr. Christie briefly about the triple bottom line. That needs to be embedded in our approach to things. We need to re-examine everything from procurement to frontline practices with a sustainability lens. We can align our initiatives with quality improvement. The naysayers who present obstacles need to be replaced with solution-based leaders. We need to actively share our ideas, our wins and our losses, and learn from and help others in our sustainability journeys to get to our common goals even faster. We need to increase awareness and education. We need to attend rounds like this and give rounds. We need to demand action and challenge the status quo. You all need to commit to make changes within your own environments. The government and hospital administrative environments can be a challenge to navigate. And with so many stakeholder groups, getting things done can take time. But I'd like to say, remember this, your voice matters, so make it matter. Thank you.
Thank you so much, Dr. Abbass. So I think we're going to start with our Q&A now. So if we can have the panelists turn their videos back on. And Dr. Abbass, if you just wouldn't mind stopping your screen share. Thank you. Perfect. So we're going to start off. I'm just going to spotlight everyone here. So we're going to start off with a question from the Q&A, and I think this is directed at everyone here, all the panelists. So the question is asking, why is it important to reduce greenhouse gases in healthcare when there are so many larger contributors globally? Could it not be argued that healthcare is necessary and life-saving, and its use of tools that may cause carbon is justified? How do we convince stakeholders and policymakers that it's still important? So whoever would like to start. Jean, since you're unmuted, do you want to start on it?
Unmuted.
I'm happy to say something.
Yeah, go for it. Like.
Sure. No worries. So healthcare's gotten a free pass for a long time.
Yeah.
And yes, it's true that our, contribution, as you heard, say 5 to 6% of national emissions. But as an individual who generates a lot of those emissions and does right by my, does my recycling and everything at home, yet my impact at work is orders of magnitude more, it's unconscionable for me not to do anything. To say that it's medical care is necessary, sure it is, but there's way better, less carbon intensive and waste intensive and resource intensive ways of doing it. And we need to figure those out. Many have been figured out, as you've seen, and we just need to emulate them and implement them. And for the rest, come up with ways to reduce our impact. We cannot make excuses for ourselves and say that we don't, that it's necessary and we should just go about as business with our business as usual.
And I'll just add to Ellie's comment. We had this discussion really at the CADIF symposium, and I think that along the lines of healthcare has received a pass. To be perfectly honest, I don't think in healthcare we've even attempted to measure what we're doing. Certainly in Canada, we haven't been doing that. There's been groups who have, but for the most part, it hasn't been on the mindset of even when we bring a device into the market, what does that device look like? How does it impact? How do we measure the impact on the environment that we're in? And our work shows really low-hanging fruit for the most part. And so many of these things just have sort of gotten a pass and no one's really actually mindfully implemented them into the healthcare system, when in actual fact, with just a small amount of innovation like we've heard about today, we can actually mitigate. And so I think we no longer, we have an ethical responsibility to be more mindful. And when we do find some solutions, or there are low-hanging fruit for solutions, that as healthcare providers who care about the impact of the environment on our patients, that we have to take our own environment and take it into account and do something about it.
Yeah, I don't think I have much more to add to those points. I think that it has to happen. I agree that there's been a pass for too long. I guess just a couple of things to emphasize. So I don't think that if you really look at the different aspects of what's contributing to our carbon footprint or our global warming footprint, some people say 4 or 5%, 6%, whatever, is not a very big number, but you put it in context with the other things that people are very actively trying to change, it's kind of on par or one of the leaders, right? So in that context, it's not insignificant whatsoever. I think another important thing is, as Dr. Abbass pointed out with the cycling analogy, every little bit you move makes the next little bit easier. And the reality is, within healthcare, what we say and what we do and what we advocate for is highly respected and listened to carefully, right, by the general population. And that's been shown over and over and over again on almost every topic that's questioned about, right? So if it's if people use the argument that it's a small piece of the pie, if you can get that piece of the pie moving because people listen to you, then I think that that's absolutely worthwhile doing. And then the last piece is that it's well recognized that as the planet warms and as these things change, it is impacting our health. So it's a bit counterintuitive for us just to do things which we know is going to negatively impact our population's health in the future, and unfortunately, disproportionately so. So the people that are not really the ones that are using all these high carbon therapies or treatments or what have you are the ones that are gonna get it the worst. So that's not a fair thing either. We have to be aware of that.
Great. Thank you so much, everyone, for your responses. We have another Q&A. And so Mackenzie says, thank you for sharing all the ways you've made changes so far. It's been really eye-opening. What projects are in your sights for next steps and future QIs? So this could be for everyone. If whoever wants to share can go ahead.
Sure, I can start there. There's a lot of stuff that's on my radar, but one of the ones that two things. One is a clinical waste education module for our entire network. Done a deep dive into these things, and now we just need to sort of put a nice learning module together to add to all the other learning modules that we take. But I think it's super important and needed. The other thing, there's no federal or provincial, at least not in Ontario, mandate for hospital pharmaceutical waste, where it goes. There is for cytotoxic waste, it goes into red cytotoxic bin. But for all the other pharmaceuticals and pretty much everything I use in the OR, because none of that stuff's cytotoxic, people throw it in the sink, people throw it in the garbage, goes into the landfill, gets into the water table, but there's absolutely no provincial guidance or legislation. So we've done some best practice investigations, Australia, UK, US, taking whatever guidances that we do have and come up with our pharmaceutical waste policy. And we're hopefully over the next few months going to be able to implement that and get the clearance from the Ministry of Environment, Conservation and Parks in Ontario. They said that they're going to look into this as well after the election, which is upon us. They realize the gap and that something needs to be done. So that these are two of the things that are next steps for me.
Oh, sorry, go ahead.
Go ahead,
Jean.
Jane. So I can just say from the working group, the inhaler working group, we've sort of taken the first steps around things like emissions, but we are well aware of the fact that DPIs also have plastic chambers, and there's the disposal aspect of it, and looking at those things. So there are folks who are looking at that, and we're waiting for that data to sort of help inform our next steps. The other is really around recycling options for community-based pharmacies and primary healthcare centers, where our patients could potentially bring their inhalers back, and that there would be some kind of a ongoing recycling program that could support them within the pharmacies in the communities. And so those are sort of next steps that are on our to-do list as we sort of look at some of this. And then, like I had said before, we're looking at trying to engage at a national level to sort of have an impact. So
Yeah, I think there's there's too many things to do, and I think we're all like to move as many mountains as we can. I guess immediate things around here is our undergraduate medical curriculum is currently undergoing a refresh, and I'm helping rewrite in some environmental aspects into that, which has been lacking. So that's taken a bit of time. We're looking at that through the whole 4 years of the undergraduate curriculum. So that's one thing. We're working on trying to quantitate through some different types of life cycle assessment techniques in terms of quantifying the ratio of benefit to harm for different procedures. And the other thing that we've gained a bit of traction and we're hopeful for is we're trying to embed a sustainability office within the C-suite of our provincial health authorities. So to be able to have some bite behind some of these initiatives if it's coming from the top down. So that's what we're trying to do.
Thanks for sharing all of those. It's exciting to hear where everyone's next steps are going. We have a question, I think, for Jean. So in terms of, I think this is asking, like, how do you overcome the resistance of management to properly fund nurses, specifically, who are engaged in sustainability initiatives in hospitals? So this isn't like an additional task and burden to their already very heavy workload.
That's a great question. Pre-pandemic, I might have even had a better answer for you than I currently do. I think the only thing that I would say at this point is that the environment and being involved in environmental issues is no longer sort of, this is a small group over here and that's what they do and the rest of us are kind of doing our thing. It's now on a national, global conversation that no longer can be ignored. And so I think, you know, engaging with whatever project is happening and having conversations with managers about it, it really can't be sort of gaslit or put on the back burner any longer. It's really a topic that has to be addressed by all the healthcare managers. And so, you know, I would just say to, you know, to have the conversation and to look at options that the physicians here have sort of provided. Sometimes I've been a nurse manager in my past life, and sometimes talking about cost, getting into the nitty-gritty of not only how we can change, but also how we can save money and how we can divert that money to someplace else, and to provide a better option for patient care. When you couch it in those different conversations, you probably will engage those individuals in a much more meaningful way than you might have if you aren't having those kinds of conversations. But that's just my thoughts.
Thank you so much. And then for our final question.
If I may, I'm just going to add something to that. You know, give rounds. Peer pressure is a great thing. Just set up rounds, call the managers, call the director, call whoever you can, and then share it with everybody. I've seen the amazing effect of positive peer pressure just recently. As I mentioned, the TASN community of practice, senior leaders from each of the TASN hospitals, Toronto Area Health Sciences Network, are at this table. And Fiona Miller, who runs the Center for Sustainable Health Systems, has certain initiatives. Everybody hears about them. They hear, okay, hospital A and B are doing it. And then champions within these other hospitals tell their leaders, hey, we don't want to be left behind. Let's get this done. And I've seen tremendous speed of movement recently. It's very heartening. It's amazing. So give rounds, get people involved. I mean, senior leaders are already hearing about this stuff, and they're starting to get engaged, as I said, and everybody along the hierarchy will eventually follow, hopefully.
Thank you. It's great to hear from both of you on this. And so we only have 1 minute left. So the final question, maybe Dr. Christie, if you don't mind. It seems as though a lot of these changes involve making the default option the more sustainable option. Could you discuss how we can advocate for these changes at a systems level to make our default options more sustainable?
Yeah, no, I think that's a great question. And I can't speak to every jurisdiction across the country or even to just Halifax and Toronto, but I can tell you that one of the challenges to making the sustainable options the default options is the way, at least in our place, the way the budget and procurement are done. So people tend to look year to year, or they look 4-year election cycle to 4-year election cycle, and no one really looks in the big picture. And for most of the procurement people, they want to keep their bottom line at the lowest. So it's, well, you know, Dr. Abbass pointed this out, that reusable things are shown to be better over the long term than single-use items. But single-use items to a 1-year budget is usually better for the majority of things. Now, maybe if you're using as many LMAs as Dr. Abbass uses, you can save something in a year, but generally speaking. So I think that we need to educate people to look at a bigger picture. And it's like, we have to start thinking of our healthcare system more like the mortgage you get on your house or a loan you get on your car, and it's not a 1-year or a 4-year cycle. And I think that's important. I think the way you do that is I think we have to get our higher executives to really embed sustainable issues into our procurement system. And if our procurement system looks at things through an environmentally friendly lens, we will start purchasing more reusables than disposables. And by the very nature of having that written into the procurement process, it's going to nudge, if not force, our industry colleagues to start thinking how they do things, right? And it's going to have a bigger knock-on effect. So I think the answer to the question is it's challenging, but we need to get our executives to embed these issues into our procurement process.
Perfect. Thank you so much, Dr. Christie, for that. And thank you to all of our speakers for coming and discussing today a lot of really interesting projects and ideas and kind of overarching topics as well. And just want to say that we really appreciate your time and your knowledge today. So thank you so much. And also thanks to our attendees. Thanks for coming and participating and asking questions. We really appreciate it. And we're really excited to see you all at our last session in 2 weeks. I can't believe how fast this is all gone. So thank you so much again to our panelists, and I hope everyone has a great evening.
Well, thank you for having us.
Take care.
Thank you, everyone.
Bye.
Thanks, Emma. Bye.
Bye.
Well done.
Well
Yeah.
done to you all.
Yes, thank you so
Thank
much
you.
for coming.